Okay, hello everyone, and welcome to the discussion of the fourth MCQ paper on pediatrics. Okay, so so far we have done three MCQ papers, right? And there we focus mainly on the commonly questioned exam areas and topics in the previous ERPM exams. Okay. Now, in this paper, we'll be focusing on some areas which have not been commonly questioned, but still which can appear in your exams, right? So, before facing exam, you'll be thorough on each and every area, right? Because questions can come from any area. Therefore, in this paper, we are focused on some areas which have not been commonly questioned in previous ERPM exams. Okay, right. So with that in mind, let's continue with the true false paper. Okay, right. First question. Breastfeeding is contraindicated in HIV positive mother. Right. Now, there are few contraindications for breastfeeding you should know of. Right. Now, HIV positive mother. Now, historically, HIV infection in mother was a contraindication for breastfeeding. Right. But now, with the introduction of treatment, right? Antiretroviral therapy for HIV, right? Now, this contraindication is not practiced commonly, right? So what they say is if the benefits of breastfeeding outweigh the risk of HIV transmission, mothers can still breastfeed, right? Now, if the mother is on, effective antiretroviral therapy, and if the infant is receiving prophylaxis, right, then we can still consider breastfeeding. So therefore now, right now, the current practice is HIV is not a strict contraindication for breastfeeding. Right? But just know HIV can still be transmitted via breast milk and also transplacentally and also during delivery. Okay. Right. So it's not a strict contraindication in the modern day practice. Okay. So it should be taken as false. Heart failure mother. Right now, uh, heart failure is not a contraindication for breastfeeding. Right? Because uh, breastfeeding has multiple advantages. Right? It improves infant immunity, improves bonding, right? It improves maternal oxytocin release. So therefore, breastfeeding has multiple advantages. Right? So heart failure is not a contraindication, right? But if the mother is critically ill, if she is severely dyspneic, or if she is hemodynamically unstable, there we can temporarily stop breastfeeding, but heart failure per se is not a contraindication. Okay. Right. Child with primary lactose intolerance. Okay. Now, what is meant by lactose intolerance? Right. Breast milk contains lactose. Okay. Now, this lactose is broken down into glucose and galactose by the enzyme lactase. Lactase breaks down lactose into glucose plus galactose. Right? Now, if there's a deficiency of this enzyme lactase, what happens is this lactose remains undigested. Right? This lactose, it remains undigested. Now, what happens is increased lactose can lead to osmotic diarrhea. Can lead to osmotic diarrhea. plus what? Severe dehydration. Osmotic diarrhea plus severe dehydration. Right? Now, therefore, if the baby is having primary lactose intolerance, it's advised not to breastfeed. Because breastfeeding, it can lead to severe diarrhea and also dehydration. Right? Now, remember, very important, it's the contraindication is for primary lactose intolerance. Primary. Right? Then there's another entity called transient lactose intolerance. Right? Transient lactose intolerance, which occurs after an episode of acute gastroenteritis. Right? So there, breastfeeding is not contraindicated. Okay. The contraindication is for primary lactose intolerance, where there's congenital deficiency of the enzyme lactase. Okay. Right. Child with galactosemia. Okay. What is galactosemia? Right. Now, galactosemia is a metabolic disorder which occurs through deficiency of a certain enzyme called GALT enzyme. Right. GALT enzyme. Right. Now, what does this GALT enzyme do? Right. So it basically metabolizes galactose. It basically metabolizes galactose. Metabolizes galactose. So if there's a deficiency of this enzyme, what happens is there's accumulation of galactose. Right? Now, this galactose can go and deposit in various organs, into multi-organ complications. Right? Now, why breastfeed is contraindicated in galactosemia? Because breast milk contains lactose, and that lactose is broken down into glucose and galactose. So, if there's galactosemia, this galactose can accumulate, leading to the complications I mentioned earlier. Okay, so that is a clear contraindication. Cleft palate and cleft lip. Right? Again, these two are congenital conditions, cleft lip and cleft palate. Right? Now, what you know is with cleft lip and cleft palate, there can be difficulties in feeding, especially because the sucking and swallowing might be difficult with these conditions, right? But still, sort of contraindication, right? We always encourage breastfeeding in the children, right? But we have to go for special management options in these children, like special portioning, uh, assisted feeding, like management options have to go if we are breastfeeding the children. And especially in the children, breast milk reduces the occurrence of certain complications like infections or that is media, right? That's reduced by initiating breastfeeding, right? So we always encourage breastfeeding in these children, all right? So that is false. It's not a contraindication. Okay. True or false regarding birth injuries? Caput succedaneum is limited by suture lines. Right now, what is meant by caput succedaneum? Right, so it basically means there's edema of the scalps of tissue. Edema of the scalps of tissue which occur as a complication of birth injury. Right, so during birth, if the presenting part of the fetus uh, presses against the cervix, it can lead to a swelling above the periosteum, in the subcutaneous tissue layer. That's what we call caput succedaneum. Caput succedaneum. Okay. So here in this image you can see caput succedaneum. It is occurring above the periosteum. Right, above the periosteum in the subcutaneous tissue layer, and therefore it can cross the suture lines. And because it occurs superficial to the periosteum, it can cross the suture lines. No, that's the importance there. But compared to capillohematoma, not capillohematoma, right? So you can see capillohematoma here, right? It's a form of subperiosteal hemorrhage which occurs due to the rupturing of vessels during delivery, right? So therefore, because it occurs subperiosteally, it cannot cross suture lines, right? Capillohematoma, it cannot cross the suture lines. That's the very important difference between capillohematoma and also caput succedaneum, right? Then is third one called uh, subgaleal hemorrhage. And subgaleal hemorrhage, you can see here, right? It occurs beneath the epicranial aponeurosis. Right? The importance of that is it can spread to orbits and the nape of the neck. Right? So it's very important to know the difference between these three conditions: caput succedaneum, capillohematoma, and also subgaleal hemorrhage. Right. So the stem says caput succedaneum is limited by suture lines. Now we discuss that is false, right? Because it occurs above the periosteum, it can cross the suture lines. Okay. So that is false. But remember capillohematoma, it is limited by suture lines. It does not cross the suture lines. Right? It does not cross the suture lines. Okay. Capillohematoma subsides usually within 2 days. Right? Now we discussed capillohematoma occurs due to the rupture of vessels during delivery, and it occurs as a subperiosteal hemorrhage. Right? Subperiosteal hemorrhage. Okay, so therefore it takes some time. It takes some time to subside. Right? Takes time to subside. Usually takes around weeks to subside. Right? Takes around few weeks to subside. But caput succedaneum, it subsides within 48 hours. Within 48 hours. Right? Unilateral facial nerve palsy is a recognized feature. That is also true. Why? Because sometimes, especially during these forceps deliveries, it can lead to compression of the fetus. Right? So in those situations, the facial nerve can get compressed. Right? So it's a complication of especially these assisted deliveries with forceps. Right? So what are the clinical findings you would get in a child with facial nerve palsy? Right? So they are unable to close their eyes, and the nasolabial fold might be absent. Yes, and then you can also see a mouth deviation while the baby is crying. Okay, so those are the clinical findings you would get in a child with facial nerve palsy. Okay. Waiter's tip position in arm seen in Klumpke's palsy. Right, so we discussed this in detail in one of our previous papers as well. Okay. This classic waiter stiff posture where the arm is adducted. Arm is adducted, then intern rotated, right? And the elbow is extended. Elbow is extended, and also the forearm is pronated. Forearm is pronated. So this classic waiter stiff posture is seen in what? It's seen in Erb's palsy. It's seen in Erb's palsy where there's a C5, C6 injury. Right? Where there's a C5, C5, C6 injury, commonly due to shoal dystocia. Right? Shoal dystocia, it affects the muscles like deltoid, then your supraspinatus, infraspinatus biceps, right? Leading into this patelis arm, patelis tip posture. Right? So that is false. It's seen in Erb's palsy. Then what is Klumpke's palsy? Right? So Klumpke's palsy is a lower brachial plexus injury. It's a lower brachial plexus injury which mainly affects C8 to T1. Right? So there you get a prominent hand weakness and sometimes claw hand as well. Right? And weakness plus a claw hand. Plus a claw hand. Okay. Clavicle is the commonest bone to fracture during labor and delivery. Okay. Now, this is also true. Clavicle is the commonest bone to fracture during birth, especially conditions like shoulder dystocia, then macrosomia, instrumental delivery, right? There, it can lead to fracture of the clavicle, right? So how do these children present if there's a clavicular fracture? Okay, so there can be reduced arm movement, right? Reduced arm movement can be noticed, and sometimes the baby might cry while handling. And then in reality, you can also feel a crepitus over the clavicle, right? So, however, the treatment here is mainly conservative, and it's benign, self-limiting, no need of any particular treatment. Okay? So that is true. Okay. Which of the following cardiac manifestations are compatible with the condition? Turner syndrome, coarctation of aorta. Right? Now, Turner syndrome occurs due to a chromosomal deletion leading to 45XO karyotype, Turner syndrome. Right? Then there are certain classic physical features of a Turner syndrome, right? Like short stature, taped neck, then shielding chest, widely spaced nipples, right? Lymphedema, right? Those are the physical features of Turner syndrome. And it can also lead to hypogonadotrophic, hypogonadism, hypogonadism, right? So these are the uh, physical features and manifestations of Turner syndrome, right? Then remember there are some cardiac manifestations as well, right? Some cardiac manifestations as well, right? So there are altogether two classic cardiac manifestations of Turner syndrome, right? So one is coarctation of aorta, right? And the other one is bicuspid aortic valve, bicuspid aortic valve. So these two are the common cardiac manifestations of Turner syndrome. Okay. Noonan syndrome, pulmonary stenosis. Right, Noonan syndrome. Right. So Noonan syndrome also has certain classic physical features. Right. So one is short stature, short stature. Then low set ears, low set ears. Hypertelorism, and then there's an associated developmental delay as well. Developmental delay as well. Right. Now, again, the classic cardiac lesion you get in Noonan syndrome is pulmonary stenosis. Right? Pulmonary stenosis. Okay. That is also true. Rheumatic fever, mitral stenosis, that you all know. Rheumatic fever, it occurs due to antibodies against the strep, cross-react. So rheumatic fever occurs due to uh, antibodies attacking or cross-reacting with uh, antigens of a group-based strep, right? So it can affect multiple body organs, including heart tissue, then joints, central nervous system, and also skin. Right, so we discussed earlier as well. So once it affect the heart tissue, it can involve the endocardium, myocardium, and also the pericardium. Right, so it can involve multiple valves. It can involve mitral valves and also commonly aortic valves. Right, so initially, in the acute phase, we can see more regurgitant murmurs in the acute phase. Right, so once it becomes the chronic heart disease, it can lead to fibrosis and stenosis. Right, fibrosis and stenotic murmurs. Okay, so that is also true. Rheumatic fever can lead to mitral stenosis, especially the chronic form. Marfan syndrome, ventricular septal defect. Right, what is Marfan syndrome? Marfan syndrome is a connective tissue disorder. Connective tissue disorder, which is autosomal dominant. Right? Autosomal dominant. Right? Now, the classic cardiac lesion you get in Marfan syndrome is aortic regurgitation. Right? Aortic regurgitation, because it can lead to the dilatation of the aortic root. Dilatation of the aortic root, so it can progress into aortic aneurysms, dissections, and also regurgitation. Okay? Right. That is false, right? It's commonly aortic regurgitation. Congenital rubella, patent ductus arteriosus. Right, now we discuss multiple times regarding this classic triad of rubella. Okay? Classic triad of rubella. What is a classic triad? So one is cataracts, right? Then sensory neural deafness, and third one is congenital heart disease in the form of patent ductus arteriosus. Yeah, this is a classic triad of congenital rubella syndrome. So. Which of the following aseptic methods used correctly match with the procedure? Cleaning skin for blood culture, povidone iodine. Right, now, first you need to know about the definition of antiseptics, disinfectants, and also sterilization. Right. Antiseptic, then disinfectant, and finally sterilization. Right. Now, these antiseptics, those we mainly use on living tissue. Right? On living tissue. For example, chlorhexidine, povidone iodine, alcohol. Those we use on living tissue. Right? Examples are chlorhexidine, then povidone iodine, and alcohol. The disinfectant we mainly use on non-living surfaces. Right? non-living surfaces. For an example, sodium hypochlorite, which is also called bleach. Right? Bleach that we use on non-living surfaces. Right? That is meant by sterilization. Right? It basically means destroying all the microorganisms, including spores. Right? Destroying all microorganisms, including the spores. For example, autoclaving. It's a form of sterilization. Okay, so you need to know these basic concepts before answering this question. Okay. Cleaning skin for blood culture, povidone that is true. Right? Blood cultures, uh, they are at the risk of being contaminated by skin flora, especially the staphylococci. Therefore, we have to use a form of antiseptic. Right? So povidone is a good antiseptic we can use for to clear these organisms. Okay, so that is true. Cleaning a blood spoilage in the ward, chlorhexidine. Right? Now here, to clean a blood spillage, right? Blood spillage, we have to use a form of disinfectant. Right? Form of disinfectant like bleach. Right? Chlorhexidine, is a antiseptic, which is mainly used on living surfaces. So that is not appropriate to use here. Okay, so that is false. Washing hands before lumbar puncture, soap and water. Right? Now, before performing a lumbar puncture, the single most important step of infection prevention is good hand hygiene. Right? Good hand hygiene. Right? So there we can use soap and water and also alcoholic hand rubs as well. Right? So that is also true. So apart from soap and water, we can also use alcoholic hand rubs. Cleaning genitalia before catheterization, surgical spirit. Right? Now, surgical spirit contains alcohol. Right? Now, this alcohol, it can sort of irritate the mucosa surfaces, and also it can lead to severe pain. Right? So therefore, to clean genitalia, we do not use this surgical spirit. Right? Instead, what we can use is we can use sterile saline. Then also we can use povidone, and also chlorhexidine. Chlorhexidine. We don't use surgical spirit to clean the genitalia. Okay, so that is false. Cleaning the skin before any puncture, sodium hypochlorite. Now we discussed earlier, sodium hypochlorite is a disinfectant which is mainly used in non-living surfaces. Right? So to clean skin before any puncture, we commonly use 70% alcohol or povidone. Right? To this we can use 70% alcohol or povidone. Bleach is not used. It's mainly used for non-living surfaces. Okay. Okay. Regarding prenatal infections, parvovirus B19, Hydrops fetalis. Right. Now, regarding these congenital infections, you need to know about these classic torch infections. Right. Classic torch infections. What are torch infections? T is for toxoplasmosis. T is for toxoplasmosis. Then O is for others, which includes syphilis, varicella, parvovirus, HIV, right? Syphilis, varicella, parvovirus, and HIV. Then R is for rubella, C is for CMV, and H is for herpes simplex. Right? So it's very important that you know the manifestations of these infections in the fetus. Very important. Commonly questioned exam area. Okay? Right. Parvovirus B19, Hydrops fetalis. Right? Now, this parvovirus, it infects the erythroid precursor cells in the fetus. Right? It mainly infects erythroid precursor cells, leading to a very severe anemia. Very severe anemia in the fetus. Right? Now, what happens is with the severe anemia, it can lead to a high output cardiac failure. High output cardiac failure, which can lead to accumulation of fluid in the third space, which is also called hydrops fetalis. Accumulation of fluid in the skin, pleura, then abdomen, pericardium due to high output cardiac failure. Right? Can lead to hydrops fetalis. Right? That is true. Varicella limb hypoplasia. That is also true. Particularly if the infection occurs during 8 to 20 weeks in the pregnancy, it can lead to this entity called congenital varicella syndrome. Congenital varicella syndrome, which has certain manifestations. So one is limb hypoplasia, then there can be eye abnormalities, and also certain neurological deficits. Right? So that is also true. Toxoplasmosis hydrocephalus. Right, now it is the classic triad of toxoplasmosis, very important. Okay, the classic triad of toxoplasmosis is, first one is hydrocephalus, then chorioretinitis, and third one is intracranial calcifications. Right? Now, remember the difference between toxo and CMV is, in toxo you get intracranial calcifications diffusely, but in CMV you commonly get these periventricular calcifications. This is a hallmark feature of CMV, periventricular calcifications, right? Not diffuse intracranial calcifications in CMV. Okay? Rubella, sensory neural deafness. Right? We discussed about the classic triad there. What is the classic triad? First one is sensory neural deafness, then eye defects and congenital heart disease in the form of patent ductus arteriosus. COVID-19 in mother, multisystemic inflammatory syndrome of newborn, MIS-N. Right? This is also true. Right? Now, if the mother gets a COVID infection during pregnancy, it can lead to a particular syndrome which we call multisystemic inflammatory syndrome of the newborn. Right? So what they say is, with COVID, there's production of maternal antibodies. So these maternal antibodies can go on and it can produce an inflammatory reaction in the fetus, right? Inflammatory reaction in the fetus, which can lead to multi-organ manifestations, right? Like shock, myocarditis, respiratory distress, fever, likewise, that can lead to multi-organ manifestations, right? So that is also true. Okay. Question. Preterm infants have higher nutritional requirement compared to term infants, right? So what is meant by preterm? Right? Preterm babies mean those children born before 37 weeks of gestation. Right? Babies born before 37 weeks of gestation. Right? Now, the important thing is normally during pregnancy, during third trimester, in fact, there's transfer of these nutrients from mother to baby, especially this calcium, then iron, phosphate, then some proteins. So these are transferred from mother to baby during third trimester, right? Now, most of these preterm infants, they miss this transfer of these important nutrients, right? So hence, they are at increased need of these nutrients. Therefore, their energy requirement is slightly higher compared to a term baby. So typically, they require around 110 to 130 kilocalories per kilogram per day. Okay? That is true. They have higher nutrition requirement compared to term babies. Doubles birth weight in 12 weeks. Now you know the term infant, usually the birth weight doubles by around 5 months. Okay. The term baby, birth weight doubles by around 5 months. Okay. But in a preterm infant, they have this classic growth pattern called catch-up growth. Catch-up growth. So therefore, their growth rate is higher than a term infant. And therefore, usually in many preterm infants, birth weight doubles slightly earlier by around 3 months. 3 months or 12 weeks. Okay? That is also true. Are mature enough to suck and swallow at 35 weeks. Okay. Now that is also true. So this neurological maturation occurs by around 34 to 35 weeks, right? So therefore, infants born before 35 weeks, they have high risk of complications like aspiration. And that's why these extreme premature babies who are born before 35 weeks, they require NG or tube feeding. Okay, so that is true. By around 35 weeks, they are mature enough to suck and swallow. Enteral feeds should be introduced after 48 hours. Right now, in modern day practice, they encourage early enteral feeding. Right? Early enteral feeding because this early enteral feeding has certain advantages. And so one of the most important advantages is it can stimulate gut maturation. It can stimulate gut maturation. That's the most important advantage, right? Now, if we uh, delay enteral feeding, it can lead to certain complications like gut atrophy, then feeding intolerance. Therefore, usually we introduce enteral feeding before 48 hours, even in a preterm infant. So, after 48 hours should be taken as false. Poor bone mineralization is prevented by provision of calcium supplements. That is also true, right? Now, one of the classic complications of prematurity is this metabolic bone disease of prematurity. Metabolic bone disease of prematurity, which again occurs due to uh, reduced transfer of the nutrients like calcium and phosphate in the third trimester. So therefore, it can lead to metabolic bone disorder, which includes osteopenia, fractures, rickets-like complications, right? So therefore, you have to always provide calcium and phosphate supplements to these premature babies. Okay, it is true. Following conditions will need further evaluation. Blackish viscous stools in a 2-day-old baby. Okay. Now, what is this blackish viscous stool? That is what you call meconium. Meconium, right? So, in a newborn, the first stool, it has certain uh, ingredients like mucus, bile pigments, then epithelial cells, amniotic fluid debris. Therefore, it appears slightly blackish. Okay, so usually this meconium is normally passed within first 48 hours. That is quite normal in a neonate. But what is abnormal is uh, failure to pass meconium. Right? Failure to pass meconium, which can occur in certain conditions. Failure to pass meconium, like Hirschsprung's disease, Hirschsprung's disease. Then meconium ileus, meconium ileus. Then certain forms of intestinal obstruction. Right? So failure to pass meconium beyond 2 days is abnormal. So blackish viscous stools in a 2-day-old baby is completely normal. It does not need further evaluation. Weight loss of 7% in a 10-day-old baby. Right? Now, usually newborns, they lose some weight after birth because of certain fluid shifts. Right? But usually a newborn should regain their birth weight by 10 to 14 days. Right? A newborn should regain birth weight by 10 to 14 days. Right? So before 10 days, there can be a weight loss of around less than 10%. Right? Before 10 days, there can be weight loss of less than 10%. But here it says weight loss of 7% in a 10-day-old baby. Usually in 10-day-old baby, you should have the initial birth weight. Right? So this weight loss can mean some other problems like feeding problems or a certain illness. So we have to evaluate for that. Okay? That is true. Geographic tongue. What is meant by this geographic tongue? Right? Again, it's a benign condition in newborns, which is a form of inflammatory condition of the tongue. Right? So here the tongue appears reddish with white borders. Right? Reddish with white borders, and it's usually benign and self-limiting. No need of any investigations. Okay? That is also false. Projectile vomiting in a 3-week-old baby. Okay. Now, whenever we see projectile vomiting in a 3-week-old baby, what is the first thing we should come? What this is the first thing should come to our mind? And that is hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Right. So classically, around 2 to 8 weeks of age, they present with this projectile vomiting in this condition. Right. Projectile non-bilious vomiting. Okay. So it needs further evaluation. Palpable liver of 1 centimeter below the right costal margin in a 6-month-old baby. Right? Now you may experience this in a uh, young baby, infants and young children. Usually, the liver edge is palpable because their abdominal wall is thin and the liver is proportion larger. Normally, the liver is palpable around 1 to 2 centimeters below the right costal margin. Right? So that is quite normal in a young child below 1 year old. Right? But if there are some red flag features like significant enlargement, like 3-4 centimeters below costal margin, right? A significant enlargement. If there's a firm tender liver, there's a firm tender liver, and if there's associated jaundice or splenomegaly, failure to thrive, right? Associated jaundice, splenomegaly, failure to thrive. So there we should consider some other differentials like heart failure, hepatitis, then storage disorders, malignancies, right? But a 1 centimeter liver alone in a healthy infant is quite normal. Okay, so that does not need further evaluation. We should evaluate only if we see these red flag features. Okay, right. This question: Wilson disease in children, autosomal dominant disorder. Right now, this Wilson disease is a condition where there's excessive accumulation of copper in certain organs like liver, then brain, cornea. Accumulation of copper in certain organs like liver, brain, and cornea commonly. Right? Now, what happens here? Right? Now, usually what happens in normal person is dietary copper is absorbed in the intestines. Then that copper is transported to the liver, and there the copper is incorporated into an enzyme called ceruloplasmin, ceruloplasmin, and the excess copper is excreted in the bile. Right? But here what happens is there's failure of biliary copper excretion. Right? There's failure of biliary copper excretion. Right? So there's increased copper accumulation in certain organs. That's what happens in Wilson's disease. Okay? Autosomal dominant condition, no, it's an autosomal recessive disorder. Acute hepatitis is a known presentation. Right? Now, this Wilson's disease can present with a wide range of hepatic manifestations. Right? So, one is there can be asymptomatic elevation of liver enzymes. Right? There can be asymptomatic elevation of liver enzymes. Then there can be acute hepatitis. Acute hepatitis. Then chronic hepatitis can also lead to cirrhosis. Can also lead to cirrhosis. Okay. So the stem says acute hepatitis is a non-complication is that is true. Neuropsychiatric manifestations are common in the second decade. That is also one of the classic features of Wilson's disease. And especially if this copper, if it goes and deposit in basal ganglia. Basal ganglia can lead to certain neuropsychiatric manifestations. right? Like tremors, dystonia, rigidity, dysarthria, chorioathetosis, Parkinsonism, right? And also certain psychiatric manifestations like depression, personality changes, aggression, psychosis. So likewise, there can be multiple neurological and psychiatric manifestations if the copper goes and deposit in these basal ganglia. Okay, that is true. Elevated serum ceruloplasmin levels is a feature, right? Now, you know what happens is in Wilson's disease, there's impaired incorporation of copper into ceruloplasmin. And therefore, the serum levels of ceruloplasmin is low. Right? Ceruloplasmin level is low, it's not high. Okay, so the typical investigation findings here. Right? So ceruloplasmin levels, that is low. Then urinary copper levels, that is high. These are the classic findings, lab findings in Wilson's disease. Ceruloplasmin level is low and urinary copper level is high. Okay, that is false. Penicillamine is used for treatment. Okay, what is penicillamine? Penicillamine is a copper chelating agent. Okay, it's a copper chelating agent. So basically, it binds with copper and it increases urinary copper excretion. So ultimately, it reduces body copper composition. Okay, so it's a copper chelating agent which can be used as treatment for Wilson's disease. Okay, so we can there are some other options as well. One is zinc. Zinc can be used as a uh, because it reduces copper absorption in the intestine. Zinc, and also we can use what we call triantine. It is also another chelating agent. Triantine. Okay. Group A streptococcal infection is associated with glomerulonephritis. Right? Now you all know group A strep can lead to post-strep glomerulonephritis. Can lead to post-strep glomerulonephritis. That is true. Impetigo. Right? Impetigo is a superficial bacterial infection which is caused by commonly Staph aureus, and also group A, strep. That is also true. Ticks, right? Now, these ticks can occur in a specific syndrome called PANDAS syndrome. Right? PANDAS syndrome. What is PANDAS syndrome? Pediatric autoimmune neuropsychiatric disorder with strep infections. Okay, pediatric autoimmune neuropsychiatric disorder associated with strep infections. Right, so here what happens is the autoantibodies, they go and deposit in the basal ganglia, leading to these complications. Okay, so tics can be a feature of this PANDAS syndrome. Okay, Huntington's chorea. Right? Now, Huntington disease, you know, is a genetic disorder. It's a genetic disorder, autosomal dominant disorder, which has various features like chorea, then psychiatric manifestations, dementia. Right? So there's no association with a group staph infection. Okay. Yes. Valvular heart diseases. right? Rheumatic fever or rheumatic heart disease is a complication of group A strep infection. Right? Rheumatic heart disease is a complication of group A strep infection, right? So valvular heart diseases can occur in rheumatic heart disease. Right? It is also true. Question. Community-acquired pneumonia. Macrolides are the drug of choice for mild community-acquired pneumonia in toddlers. Okay. Now, what is meant by community-acquired pneumonia? Community-acquired pneumonia means pneumonia which is acquired outside the hospital or within 48 hours of hospital admission. Okay. Acquired outside the hospital or within 48 hours of admission. Within 48 hours of admission. Right? Now in toddlers, most of these community-acquired pneumonias are due to viral infections or strep pneumonia. Okay? Can be due to viral infections or strep pneumonia. Right? Therefore, the first line antibiotic we use is amoxicillin. Amoxicillin is the first line antibiotic we use in community-acquired pneumonia in toddlers. Right? So macrolides like erythromycin, azithromycin we use when we suspect an atypical cause like mycoplasma, chlamydia, or if there's poor response to initial amoxicillin treatment. Okay, so therefore, that's not first line. It's a second line agent we use only if we suspect a atypical pneumonia. SIADH can occur as a complication, right? What is SIADH? That is syndrome of inappropriate ADH secretion. Right? Now remember, these pulmonary infections, it can stimulate the secretion of ADH. Right? So pulmonary infections like pneumonia can lead to increased ADH secretion leading to SIADH. SIADH. Right? So clinically, they can have low sodium, then features like seizures, lethargy, nausea, okay, with this SIADH. Right? Remember, this SIADH is classically associated with pulmonary infections and also CNS infections. Also CNS infections. Okay, it is true. Oral zinc plays a role in reducing mortality in severe pneumonia. Right? Now zinc is essential for our immune function and also epithelial integrity. And therefore, we use zinc commonly in diarrheal infections, diarrheas. Right? But also, remember, it can be used in pneumonias to reduce the severity and duration. Okay? So, apart from diarrheas, we can also use zinc in pneumonias because it improves immune function and reduces the severity and duration of pneumonia. Okay? So, that is also true. Hyperinflation with bilateral interstitial infiltrates is a feature of viral pneumonia. Okay. Now there are typical X-ray findings you would get in a viral pneumonia. Right? Typical X-ray findings you should get in a viral pneumonia. So one is there's hyperinflation due to air trapping. Hyperinflation is there. Okay. Then there can be interstitial infiltrates. Okay. Interstitial infiltrates. Okay. then peribronchial thickening, peribronchial thickening. Then there are patchy bilateral changes. Okay, you know, in a bacterial pneumonia, you get a localized consolidation. Okay, but in viral pneumonias, you get these patchy infiltrates, interstitial infiltrates, unlike bacterial pneumonias. Okay. Ultrasound scan chest is highly sensitive and specific for diagnosing pneumonia. That is absolutely true. Right? Now, remember, when compared to X-ray, ultrasound scan has increased sensitivity